I'm going to spend the last 20 minutes of today talking about extracorporeal membrane oxygenation and a little bit about CRRT at the end. Here are my disclosures. None of these are related to mechanical circulatory support in any of its iterations. What I can't do in 20 minutes is review what is quite an extensive literature now on extracorporeal cardiopulmonary assist systems. And I'm not going to review in detail the various different modalities to provide support. I am going to talk a little bit about what I call ECMO made incredibly simple. I'm usually the only anesthesiologist in the room, and I'm going to assume I am again today. So I'm going to give you an anesthesiologist's guide to extracorporeal membrane oxygenation. And I'm going to stress a couple of things which I think are more important than perhaps the technical details, and they relate to patient selection. The one thing that I will tell you is that details really do matter when you're doing ECMO. At our institution, our ECMO director is an anesthesiologist intensivist, and he works with a surgeon and an interventional cardiologist who together make the deployment decisions and actually execute the procedures. So I'm going to talk a little bit about alphabet soup. What are all the V's and A's and E's and C's? What does it all mean? I am going to spend some time on indications and contraindications because I think it's really important. A few bits and pieces about circuit basics. Cannulation is probably the most important aspect of the technical procedure, so I'm going to spend a bit of time on that. And then I'm going to end by discussing the pros and cons of the various different ways you can connect the various parts of the CRRT equipment to ECMO circuits. So before we get into the technical details, it's important to talk about dollars. This is an expensive hobby by anybody's standards. To set an ECMO service up, and we know what this costs because we've done it, costs a little under $3 million just to get started. You have to buy equipment, you have to staff up, you have to pay for the people who are running the service's time, even when they haven't got a patient on ECMO. And there is a critical number, which is probably about 25 to 30 patients a year before it starts to make financial sense. And on top of the startup costs, there's about another $2.5 million a year in operating costs, which puts the cost, and obviously this depends on the number of patients you do a year, in the $100,000 per patient category, which sounds like a very lot of money. And it is. And it's important to ask the question, well, is it worth it? And I've got a couple of slides about that. But there are some costs above and beyond just the initial startup and operating costs, and they are the cost in terms of the investment you have to make in your physician staff, your nursing staff. ECMO is a very emotional experience, not least for the patient, but for the families, for the staff involved, and for the physicians. It's very dangerous, it's high risk, and bad stuff usually happens, and that takes an emotional and personal toll on staff. And we spend a lot of our time managing the effects of the program on the staff involved. And of course, it will deprive your other programs of resources. If you, like I do, run a routine cardiac surgical program as well, when you have an ICU full of ECMO and VAD patients, that impairs your ability to move patients having regular bread and butter type cardiac surgery through the unit. And you have to be aware of that when you get into this business. Now, this is a slide from the ELSO registry showing, this is from the National Inpatient Sample, which is a large administrative data set in the US, showing that ever since 2007, there's been what some would say an unhealthy increase in the incidence of ECMO. Survival hasn't really changed and cost has gone up, so why are we doing this? I mean, if you do more of something, it doesn't seem to work and it costs a lot of money. What's that about? And the answer is more people are actually living. If you increase the number and the survival stays the same, more people have lived than died because this is a relative change, of course. So in absolute terms, more people now survive ECMO than they did 10 years ago because we do it more often. I mentioned earlier on that if you're going to spend $100,000 on someone, then how can we as a community decide whether that's good value or not? And we measure that in quality-adjusted life years, which of course is the amount of high-quality life you get back. It's a way to measure that. And for some reason, we think in the US that about $50,000 per QALY is reasonable. So if you assume, and there's some pretty serious assuming going on in the next few bullet points, that the average cost of an ECMO hospitalization is $130,000 and the life expectancy is 70 years, and it's probably not, but if you assume that it is, then the numbers start to look pretty good value, especially if you're a neonate, when the cost of that intervention is just a little under $2,000. It's still pretty good if you're a 50-year-old, and I would remind everybody in the audience that 50 years is a young patient. And $6,500 per QALY is still pretty good value. So by those data at least, ECMO appears to be worth it, which in part explains the enthusiasm for its ongoing use and increasing use. So what is it? So it stands for extracorporeal membrane oxygenation, and we use it to replace either cardiac and or respiratory function. It's very, very similar to cardiopulmonary bypass, first described by Gibbon in 1953 and first used in the bedside in the 1970s, and I think Professor Ronco showed you a slide of its very early use in a baby earlier on. The thing that, and when I first started doing ECMO as a senior registrar in London over 20 years ago now, this was really not something that you were looking forward to doing. It was a complete disaster, almost routinely. And something changed, and what that thing was the introduction of polymethylpentene oxygenators, the Quadrox oxygenator in particular, which has transformed the technique in adults, at least, into something which is now survivable, and in our institution at least, for certain patients, is a routine procedure. You can deploy it to support the lungs and the heart, in which case we call it veno-arterial, or VA, or you can deploy it just to support the lungs, in which case we call it veno-venous. And the difference, the fundamental difference between the cardiopulmonary bypass situation is that with ECMO there is no blood reservoir. And that has both an advantage, but it also brings some disadvantages as well. We do not routinely use the Quadrox oxygenator in the operating room because it costs about $1,000 a time. And if, like us, you do 1,500 hearts a year, that's an avoidable $1.5 million that you don't have to spend. So the basic principle behind extracorporeal membrane oxygenation is that you drain desaturated blood from the patient, you oxygenate it, you remove the excess carbon dioxide, and then you give it back. And you either give it back into a vein in VV ECMO, or you give it back into an artery for VA ECMO. And of course, if you give the blood back to a systemic artery, then you've replaced the function of the heart. And I'll take a moment here to point out that if your cannulation is femoral and the indication is cardiac, one of the problems with ECMO as opposed to some of the other short-term ventricular assist devices is that you do not decompress the left ventricle. If anything, it further distends. So it might support the rest of the failing organs in the body, but it often doesn't provide support for the left ventricle because the blood is now coming retrograde up the aorta. That's less of a problem with central cannulation, where the blood flow is moving away from the heart, and if anything can entrain cardiac output from the left ventricle, which is a technical point which is important when you consider what the indication for support is. So we can replace or augment both pulmonary and cardiac function, and as I just said, typically the perfusate mixes in the aorta with blood from the left ventricle, which is arriving from compromised lungs, and so the oxygen and carbon dioxide content is a mixture of that of the blood coming from the lungs and also from the circuit. And so one of the ways you can measure return of pulmonary function is by the improvement in gas exchange, manifesting as changing blood gases while you don't change the circuit components. So the systemic blood flow is the ECMO flow plus the patient's own cardiac output. It's important to measure that. This is a diagram illustrating centrally placed cannulae. And I put this in here really to illustrate that this is a system that you can put together with various bits and pieces. This is a Centromag short-term either left or right ventricular assist device with the Quadrox pump, and then various other bits and pieces here. This is a purpose-built system that has a pump, an oxygenator, and the cannulae, and I'll talk about those in a little while. We use both of these. We use this device up here if we're going to another facility to salvage someone and bring them back to Vanderbilt. And we use this system if it's an in-house patient, mainly because it's considerably cheaper than the ready-built system. Now, one of the things that people don't often realize is it's much, much cheaper to put someone on ECMO than it is to put a ventricular assist device in. And probably one of our biggest patient populations is patients in whom we're not sure if there'll be neurological recovery sufficient to justify spending the $250,000 on an LVAD. So we do ECMO a lot because it's cheap. You're buying an oxygenator and a couple of plastic pipes. The rest of the cost is already included in the hospital stay. So in terms of cannulation, you have to have at least one venous access point, and as I said, that can either be peripheral or central. You have to have another place to return the blood. This is for VV. For arterial access, we used to do cut downs. Now we do this all percutaneously in our interventional lab. Traditionally, this has been the realm of the surgeons. In our institution, the surgeons remove the pipes, but the cardiologists and us put them in. So traditionally, at least femorally, you'd require a cut down with an end-to-side anastomosis you can see here. Bleeding is a big problem. Although the cardiologists are pretty good with their percutaneous closure devices, these pipes are big by dint of necessity. They have to carry a cardiac output of 4, 5, even 6 liters a minute. And it needs you to be comfortable with both the anatomy of the vessels you're getting into, but also how to deal with them if things go wrong, or rather when things go wrong. So we've moved, this is just an example of central cannulation. This is a patient who wouldn't come off bypass and therefore had the chest open, and you can see has the cannulae placed centrally. A couple of important points to mention with cannulation. You can see this is not from our hospital, but you can see that this is basically what we do. The cannulae have been placed percutaneously, which is fine. One of the problems that people haven't realized is that unless you put this guy here in, this is a cordis catheter, which is placed to direct blood flow down the ipsilateral leg. If you don't do this, then the leg drops off in about 48 hours' time, which kind of replaces one serious problem with another serious problem. So you can see here what we do is this is just teed off the regular arterial line. This is the left leg, so this is the lateral part here. This is just a blood pipe coming off the arterial line that comes around here into the side port of the cordis, and that perfuses the leg distally. That's really important to do that. And in fact, it's important to place that at the time that you place the initial cannulation. So the new pipes are larger, they're smoother, they're slicker, and they can or can't be lined with heparin depending on the anticoagulation strategy that you're using. These are the cannulae for VA use. The veno-venous cannula we use, however, is different. This is a coaxial cannula, which we usually place percutaneously in the jugular vein. And you can see here it's a coaxial cannula. It drains blood from the SVC and the IVC, and then returns it through a pipe here, which is directed echocardiographically to aim straight through the tricuspid valve. Now, the reason it's important to do an echo at the time of insertion is if you get this wrong, and you poke it through the tricuspid valve, it's very, very difficult to get sufficient flow. And you can see here, if you're not careful, you can actually poke this through the right ventricular wall. And when that happens, things get very exciting very quickly. Do not do that. So we do most of this in the cath lab. Sometimes if it's really emergently and we can't get to the cath lab, we'll do it at the bedside using transesophageal echo. And our surgeons have agreed to and do take people to the operating room to decannulate when necessary. Heparin dosing is fairly standard. We aim for an ACT of about 200. I talked about distal reperfusion cannulae and then standardized criteria for flow and oxygenation. Most commonly we use heparin. If you have to do this in someone who's got HIT or can't take heparin for another reason, it's a real problem. a real problem. We've tried to use bivalirudin, argatroban, and both of them cause problems. So as I said, we generally run an ACT of about 200 or a PTT of about 60 to 80 in order to prevent blood clotting. One of the problems, let's talk about complications, you can get hemorrhage and bleeding and clotting are basically the two big problems. So bleeding and clotting and bleeding. You can bleed anywhere, and these patients do bleed anywhere. You can have mechanical problems. You can have bits of equipment that fall apart mysteriously. Infection is a big problem, ventilator-associated pneumonia in particular. All these patients are still on a ventilator. And then the systemic problems that we've spent the last day or two talking about. If you see this is a big problem. This, for those of you that aren't aware, this is an old TE taken at my previous institution. You can see the date here is 01. This was one of the first patients we put on ECMO in the modern era, and this is a transesophageal echocardiogram. This is the left atrium. This is the right atrium. This is the right ventricle, which is nicely decompressed, and this is the left ventricle here. And as you're aware, blood is echolucent. Clot is echogenic. And this is extremely bad news. This is a left ventricle cavity completely full of blood clot. And the reason this happened is because the patient was bleeding, and someone thought it would be a good idea to give recombinant factor 7. And when you do that in a patient with a huge extracorporeal surface area, if you will, it generates widespread extrinsic coagulation and essentially clotted first the patient's heart, then the pipes, and then the pump. So don't do that. Now, who to give ECMO to? I love this quote. This is from Galen, apparently, and it's particularly relevant for ECMO. All who drink of this treatment recover within a short time, except in those who do not. So the conclusion must be that it fails only in cases that are incurable. And if you get into the ECMO business, you will see people who will tell you this sort of thinking. And the fundamental concept is only do this if the underlying condition is reversible. So H1N1 and myocarditis are probably the two poster children for ECMO because they get better. End-stage cardiovascular failure in someone who's not eligible for a device or a transplant is not a good indication. You know, and we spend a lot of our time telling people that you have to die of something, unfortunately. Because ECMO is cosmetic. It doesn't treat the underlying condition, and so it's only acceptable if you think there's a legitimate chance that the patient's underlying condition is reversible. I can't emphasize that enough. Some of the times that are, for example, failure to wean from bypass. The left ventricle is often very stunned. It may have had 3 or 4 hours of cardioplegia. It's very reasonable in most situations to suspect that acute myocardial stunning will recover. Cardiogenic shock secondary to myocarditis postpartum, probably the best indication there is, where you've not one but 2 lives at stake. Post-MI cardiogenic shock, provided you've been revascularized. Acute transplant rejection, which may buy you enough time to optimize someone's anti-rejection meds and or relist them. A bridge to transplant we've talked about. Obstructive shock secondary to pulmonary embolism. We do this a lot. We do a lot of surgery for acute PE. We give a lot of the new ICOS cannulae for systemic fibrinolysis. And that's a reasonably good indication. Drug overdose and then other high-risk heart catheterization procedures. But remember, I said it doesn't decompress the left ventricle. And we tend to use the impeller device for that in that indication. Respiratory indications, severe hypoxemia, severe hypercarbia, and then excessively high inspiratory plateau pressures. Professor Ronco talked a little bit about that. Some of the contraindications are essentially, you can summarize them as saying the underlying condition is not reversible. So I won't dwell on these given the late hour. How do people do? In this order, better for a respiratory indication than a cardiac indication than if this is being used as external cardiopulmonary resuscitation, when only about 1 in 3 patients will survive to discharge. And I think that's optimistic. These are data from the ELSO ECMO registry. I said earlier on, the more you do, the better you get. This is data from one of the most experienced centers in the United States, and they estimate that once you're up to a number of about 30 a year, that's when the payoff comes in terms of outcomes. Now, what about combining CRRT with ECMO? What are your options? Well, essentially threefold. You can either cannulate separately, in which case it's the same as any other CRRT run. You can place the equipment in line, or you can place the circuit dovetailed with the ECMO circuit, and I'll show you descriptions of that. This is what happens, or how it looks if you place the equipment in line. You can see there is a pump, there's an oxygenator here, and you can see the hemofilter itself is placed in line with the ECMO circuit, with both the dialysate and the replacement fluid separately, and then the effluent collected here. It has advantages and disadvantages we'll talk about in a minute. If you go with the separate device, all you do essentially is plug your CRRT access into the circuit such that some of the blood is pulled off the circuit and then returned. In which case, conceptually, it's very similar to managing the patient. It's just that you don't have trouble, quotes, with access for CRRT. This is a slide shown at this meeting actually a couple of years ago from David Ashkenazi, who summarized things very nicely. And this is a comparison of placing the equipment either in line or dovetailing, as I said. And in terms of ultrafiltration control, in line applications, the IV pump is controlled, and in separate applications, the CRRT machine controls it. Perhaps the most important is that if you put the pump in line, you need fewer people. If you have a separate machine, you need more people. I'm not really persuaded by that. These are very high-intensity nursing patients anyway. And I would suggest to you that any intensive care nurse who is capable of managing someone on an ECMO circuit is more than capable of managing CVVH. In fact, we tend to manage, we have an ECMO team of nurses who've been trained up to sit these patients, and they work with the consultant input from our pump techs who now no longer have to sit these. One thing that I will say is that if you can avoid CRRT, then the results from ECMO are better. This is a meta-analysis published recently focusing on both the case-control adult and pediatric literature and then the cohort studies. There's very little randomized trial data here. But in every situation here, you can see that the outcome favors ECMO alone. Now, that's a bit like saying, don't put people on ventilators because they die more often. Obviously, if someone has life-threatening renal failure, they're going to need that supported. And I think this is just really a representation that the sicker you are, the more organs failing and needing support, the less well you do. But nevertheless, it is true that if it's possible to avoid including renal replacement therapy, then outcomes seem to be better. So in conclusion, ECMO is a viable treatment modality for both adults and children who have reversible severe disease. It is not a pre-mortem treatment merely to prolong the time until death occurs. That's really, really important. The details really do matter, and I believe that it's all about cannulation. Get that right, and in general, if you get the anticoagulation right too and keep it simple, that once the underlying disease process reverses, then the patient should do well. And as I've just said, if ECMO patients need RRT, then there are several options, as I tried to point out, but outcomes generally are worse, as is the case with the rest of AKI, that if you can avoid CRRT, then you should. And with that, I thank you for your attention.